Hello, and welcome to Addressing Healthcare Disparities with Patient-Centered Homes. My name is Melissa, and I will be in the background answering any WebEx technical questions. With that, we invite you to sit back, relax, and enjoy today's presentation. I would now like to introduce your first speaker for today, NCQA President Peggy O'Kane. Peggy, you now have the floor.
Thank you so much, and welcome to our audience. I particularly want to extend a warm welcome to our patient-centered medical home people out there because, we create the product, but you all create the wonderful benefits that the patient-centered medical home makes for patients. And this first slide just illustrates, patients are getting their care from a number of different sources, and the more complicated the patient's health is, the more complicated their health care is, and therefore the need to make sure that that care, it really is coherent, that it's complete, that it's not redundant, that is the real reason we designed the patient-centered medical home. And it really, I should say, was based off concepts that had been out there, particularly among pediatricians, so I want to recognize that. But, you may have a patient who's going to, has a regular doctor, but also goes to urgent care because they have some exacerbation. They go to specialists, they go to behavioral health. And so the task of integrating all this care and making sure it all works right for the optimum outcomes for the patient, that is the big heavy lift that patient-centered medical homes do. If you go to the next slide. So what are we looking for in patient-centered medical homes? I know you homes know about it, but others may not. We want to see that there's enhanced access after hours and electronically. So often people will be going to the ER just because they can't get access when something happens and, it's outside of regular office hours. The medical home is really based on a strong long-term patient relationship with the care team. And the most highly functioning medical homes really have a very well-designed care team because we can't have all this only fall on the primary care doctor. There's a focus on prevention and managing chronic conditions to prevent costly, avoidable complications. So we know that many chronic conditions, if they're not managed right, the patient will deteriorate, there will be more exacerbations, there can be dire consequences for the patient's health. So we also know, thank goodness, that for many of them, if care is done right, we can really optimize the health of the patient. Using health IT to enhance access and care management. So we're in an age now where we have electronic tools, which ideally are going to enable the practice to be more comprehensive and more effective in its work. That sometimes feels like a promise and not quite fulfilled yet, but we're on a path where that is happening more and more. We also know that we want to see improved care team satisfaction and efficiency. And we know that if the team, this totally makes sense, right? If you have a team that feels good about what they're doing, that doesn't feel completely put upon, they're going to function more highly than a team that is disorganized. Disorganization creates a lot of extra work, et cetera. And coordinated, personalized, and comprehensive care, that's the goal. And so today our focus is on tools for reducing healthcare disparities. So another point is that patient-centered care should make better use of healthcare dollars. So there's a study here that we're referring to that shows that there's lower per capita spending for patients in NCQA recognized PCMHS, and that the annual savings for 100,000 patients in an NCQA pilot project was $5 million. So, we don't want to be crass about talking about costs, but we know that stretching the healthcare dollar and getting better results for the same amount of money is one of the challenges, and we know that more highly organized care does that. So we're very proud of there are many research studies that show this. This is actually a study from Vermont in Colorado, 2 studies. So, you know, we always look for this feedback that comes from those who have committed to the patient-centered medical home model, and we try to share that because we know that that is one of the important outcomes. Patient-centered care not only improves quality, but it reduces costly utilization. So these are articles from JAMA, Annals of Internal Medicine, and American Journal of Managed Care, and so this is a combination of things. NCQA's PCMH patients have high-quality disease management, better medication adherence, an emphasis on self-care and community support, and they thus experience fewer acute incidents. The practices are actually helping the patients take better care of themselves in many cases, because they remove a lot of the confusion that patients with complex conditions face. So, you know, they can count on their primary care practice to help them prioritize what they have to do, help them, remind them if they are falling off their meds, et cetera. So there's a 39% rate of self-care planning and community support, higher rate of self-care planning. So that's the point where the patient is making an agenda for him or herself about, here's what I need to do to help myself stay healthy. There's 5% better performance on a 5-measure objective standard of care for diabetes bundle. There's a higher rate of optimal medication adherence, which I mentioned before, and there's lower risk-adjusted use of ED services. So, I mean, sometimes there's a real genuine emergency that can't be avoided, but we know that a whole lot of emergency room use is a result of things that aren't going right in the regular management of the patient. So we're very pleased to see these results, and once again, I want to say congratulations to our medical homes on the line, because you're the ones that make these things happen. And now we're going to move on to the next speaker.
Good afternoon, everyone. My name is Raina Akindeko, and I'm the Assistant Vice President for Product Strategy and Development at NCQA. I'll be giving a brief overview of the social determinants of health and how NCQA's PCMH standards address them before turning it over to Dr. Adriana Matisse, who will do a deeper dive into them. So what are determinants? Our health is influenced by a wide range of factors: where we're born, how much money we have, the kinds of food available to us in our local grocers, whether we have adequate social supports, and if we live in safe communities. Healthy People 2020 calls these the social determinants of health. Social determinants have been described as life-enhancing resources whose distribution across groups effectively determine the length and quality of life. Lack of these resources are the root cause of healthcare disparities. Healthy People 2020 defines health disparity as a particular type of health difference that's closely linked with social, economic, and/or environmental disadvantage. While we often view health disparities through the lens of race and ethnicity, they occur across other dimensions, including socioeconomic status, age, geography, gender, disability status, and sexual identity and orientation. Health disparities largely affect groups of people who systematically experience greater obstacles to health based on characteristics historically linked to discrimination or exclusion. Affected populations have poorer health and care outcomes overall because they lack support for diagnosed conditions, receive less preventive care, and the care they do receive often deviates from evidence-based treatment. In the case of racial and ethnic minorities, it's well documented that people of color generally face access barriers and utilize less care than whites. Studies done in the last decade show that elderly LGBT individuals face additional barriers to health because of isolation and lack of social services and culturally competent providers. Disparities just don't affect these vulnerable populations. They affect everyone by limiting overall gains in quality and adding unnecessary cost to the system. And as we move to payment systems that focus on value over volume, they lower quality scores that influence payment to health plans and clinicians. While most of these social determinants that contribute to health disparities are not controlled in clinical interactions with healthcare providers, it's important that they are addressed as part of the care process. Medical care is estimated to account for only 10 to 20% of the modifiable contributors to healthy outcomes for a population. The other 80 to 90% are attributed to the social determinants. To become NCQA PCMHS, practices have to meet standards that address needs driven by these social determinants of health. Clinicians and staff in medical homes work in teams to focus on each individual's patient needs, preferences, language, and culture to overcome barriers to care by developing long-term partnerships with them. There are 6 concepts in the PCMH standards that focus practices on areas most critical for delivering patient-centered care. Knowing and managing your patients assesses the practice's ability to understand their patient population and address their needs. Patient-centered access and continuity examines whether practices are providing appointments and after-hours care. Care management and support looks at how the practice cares for patients who have additional care needs, including what social determinants of health might be impacting access to care and outcomes. Performance measurement and quality improvement requires that practices review their performance on clinical quality, utilization, and cost and patient experience to ensure gaps are identified and improvement plans are put in place. Care coordination and transitions looks at whether practices have the capability to effectively communicate and work with specialists, hospitals, and other facilities to ensure patient needs don't fall through the cracks. And finally, TeamBased Care and practice organization examines how the practices have organized themselves to ensure that staff work to the top of their licenses in training and that they communicate clearly and effectively with patients. Across the 6 concepts, there are 40 core criteria and 60 elective criteria. Practices must meet all 40 core criteria and at least 25 elective criteria to achieve recognition. The 40 core criteria are foundational requirements to delivering patient-centered primary care. The elective criteria allow practices the flexibility to select activities most meaningful to their practice. They can focus on what's most applicable and relevant to their specific patient population, practice specialty, geographic location, practice size, or practice capabilities. With that brief introduction, I'd like to turn it over to Dr. Adriana Matiz, who will give you more information on how the PCMH program addresses disparities.
Thank you, Raina. So now we will review the 6 categories, which include these 40 core and 60 elective criteria that were mentioned by Raina in further detail, and we'll share some practical examples of how the disparities that are existing in your communities could be addressed. In the first category, we'll go to this slide, sorry, the former slide. Thank you. In the first category, which is knowing and managing your patients, this is really truly at the heart of the patient-centered medical home, and it's critical for addressing disparities. If you know your patients, these standards can support the collection of data that can help the practices decrease the disparities. Starting with comprehensive assessments, including social determinants, is critical. This is where a practice can identify housing insecurity, food insecurity, transportation needs in a systematic manner. Additionally, population assessments can be done at the practice level upon registration of the patient that include capturing things such as race, ethnicity, and language will be important for collection and quality improvement that the practice can perform. Also, depression screening could be a major driver of disparities in communities, and implementing evidence-based models of care to systematically address depression in the population will be important. Communicating with patients in their preferred language will address the issues of full transparency and connection throughout the encounter and the support that the medical home can offer by understanding what are the patient's preferred languages and therefore elaborating with resources to ensure that patients understand everything that is being delivered through the medical home. Having proactive outreach of needed services will be important. It is a way where a practice can send, for example, reminders about vaccines or reminders about screening to certain subsets of populations that have been identified where barriers to care and health disparities may exist. Having evidence-based supports is another critical element. This way, the practice can identify populations that can be connected to resources that are evidence-based, such as, for example, nurse partnership programs in the community. This decreases some of the biases that might be affecting standards in care by making them evidence-based and standard. And then finally, in knowing and managing your patients, It'll be important to identify populations that may have this food insecurity and supporting their connection to food banks in their local community. Next slide. So now we will discuss some of the elective standards that can enhance the previously mentioned core standards to address disparities. In these, for example, having educational meetings with staff on site at the practice around topics such as cultural competency and health literacy can definitely impact the disparities in the community. By having cohesive team trainings, it brings to light topics and contributes to constant performance improvement with the practice. We can also implement methodologies at the practice to tailor education for each patient. So for example, if patients are identified as illiterate, the practice can implement certain measures to proactively outreach to them and anticipate their needs. Peer support and self-management is another very important standard. This is where practices may implement partnerships with community-based organizations or other programs to have peer support, such as community health workers or patient navigators, support families in developing self-management goals and care plans. Assessing patient medication response is another important standard. Assessing oral health, hygiene, and education around oral health is also an important standard where practices, for example, can develop dental partnerships where they may embed dental providers into their care teams, as well as promote, for example, the application of fluoride for populations where this may be an access issue for the dental service line. And then finally, case conferences for high-risk patients is another method where patients can be managed to reduce disparities. If a practice can identify high-risk patients that are utilizing BED often, or because of data that is reviewed from the practice are identified as having a racial disparity or a socioeconomic disparity, the practice can conduct conferences to support the family in a multidisciplinary team approach and develop cohesive care plans. Next slide. Now we will turn to access and continuity. As we all know, limited access to care is a key contributor to disparities across our nation. The core standards from the PCMH model have certain tools really that the practice can utilize to narrow these disparities and improve access. One of them, for example, is to identify populations within the practice that are high ED utilizers, and therefore the practice can develop certain mechanisms of outreach towards this population. These high utilizers may actually be experiencing high levels of social determinants of health, and therefore resources can be allocated. However, none of this can start unless the population is identified. Another aspect to improve access is to offer access after hours, by phone, by same-day appointments, by other innovative methods that can do outreach to populations that may have transportation barriers that affect their ability to access the practice during traditional times. And so having those innovative approaches can definitely contribute to narrowing the disparities. Additionally, having patient visits with a care team that's consistent is very important, as families or populations that may be experiencing disparities develop a trusting bond with their medical home, then there will be more transparency with that relationship, and we will be able to make a greater impact in reducing their disparities. On the elective side of our standards, it'll be important to assess some of the disparities in access by patient type. So for example, if a practice is able to track no-show rates by race or by language, they're able to implement certain other methodologies to do outreach. And then finally, in this section, if a practice is able to develop some innovative measures, whether it's video chatting, instant secure messaging, or telehealth visits, again, less traditional than the normal in-person visits at a practice, we'll be able to offer other modes of contact to the practice, and barriers such as transportation or times of work or other housing issues where families may be navigating the housing system and not be able to participate in traditional models of care can have access to the practice. Next slide. And now we'll turn to some of the elements that will support managing patients with care management and support of extended team members. In the core standards, one of the main things that a practice can implement is a methodology to identify patients with food and transportation needs. By doing this either through screeners, for example, in the waiting room, or by having additional team members embedded into the PCMH, such as social workers, community health workers, will allow the team to promote outreach to these families with identified needs and connecting them to community resources. Additionally, if we identify patients with behavioral conditions where an extensive number of disparities exist, we'll be able to proactively connect them. So an example may be that patients are identified with depression, and an embedded care manager that addresses their needs will be able to connect them to resources locally. And then finally, on the core standards mentioned somewhat earlier, identifying high utilization populations that are high cost in ED settings or inpatient settings of poorly controlled patients will be important. And examples of these may be focusing on patients who have uncontrolled asthma or uncontrolled congestive heart failure, where we proactively, as a medical home, promote outreach to them and adjust their care plans accordingly. Again, these are diseases that are known to have tremendous health disparities across our nation. On elective standards, if the practice is able to demonstrate methodology around risk stratification, that will prioritize care management for the practice. Examples here may be inclusive of stratifying populations, for example, in the pediatric population of medically complex children. On the adult side, it may be of patients with congestive heart failure who have frequent inpatient admissions. So supporting them and stratifying them by risk to do targeted outreach will contribute to the narrowing of the disparities. Also important will be to incorporate patient preferences into care plans. Examples here may be to really understand, well, what are the patient's goals? What language do they want to navigate the healthcare system in? Or if we're connecting them to resources in the community, where do they best identify? If they're an LGBTQ member, where will they be more comfortable and feel that they're being supported? Additionally, the practice should be addressing barriers to patient goals. And again, this may be through surveys where we're assessing social determinants of health or through working with team members in the practice. And then finally, another elective for this section would be to develop self-management plans in collaboration with other care team members, as well as with the patient and the family at the center of that plan development. Next slide. Turning to quality improvement, the core and the elective standards here can offer a framework for practices to support and promote outreach by having rapid cycle methodology from the data that is extracted at the practice level. Ultimately, this allows us to have targeted interventions that work for the practice on a very personal and tailored manner. In the core standards, tracking quality measures for disparities will be important. Example of this may be, as I mentioned earlier, tracking populations within the practice that may have low immunization rates or abnormally high hemoglobin A1Cs, or maybe in need of certain cancer screenings. And these are all areas where there is definitely a lot of body of knowledge around health disparities that exist for particular populations. So being able to track that and then promote targeted interventions is important. Goal setting for the particular patients will be important, as well as soliciting patient feedback along the way and improving the practice with the feedback that patients and families provide. Additionally, for the electives, assessing disparities in at-risk populations will be important, and this is where a practice may really quantify for certain at-risk populations, what does the data look like? What does it look like by race, by language, by gender, or by diagnoses, for example, maternal depression. Additionally, surveys will be conducted at the practice, and the PCMH promotes the CAP survey as an example, where the survey really captures the patient experience, and there are particular answers that can be inclusive of things that affect disparities. So this allows all populations in the practice to have a frontline voice in improving the practice through their feedback. And then finally, setting goals to reduce disparities will be important on specific quality measures. This may be an example if flu vaccination rates are particularly low in Hispanic population above the age of 65, then a targeted approach can be done to do outreach and promote adherence with flu vaccination. Next slide. The NCQA elements for care coordination and transitions can be very important to systematically support families around referrals and coordination of care. In the core standards, it'll be important to share clinical and demographic data for referrals to other consultants so that If the practice has this data, they're able to demonstrate that they're not only collecting it, but also handing it down to the next provider of care in the referral. This will help really optimize the care that they receive on the receiving end with the consult. The tracking and following up of referrals is critical for the practice. It allows high-risk populations who need additional support to engage with the consulting referral are not missed and do not fall through the cracks. And another area where health disparities continue to exist is the follow-up after hospitalizations or after discharge from the emergency room. And by being able to track this at the local level of the practice with outreach, it again reduces some of the disparities that many of these populations face, where they may be receiving the treatment in the hospital and the ED, but then the medical home connection is missed. So capturing these systematically and ensuring that connection happens in that transitions of care will be important. The elective standards promote a culture of continued care coordination. The ability to demonstrate collaboration with behavioral clinicians will help some narrowing of those disparities around mental health, which are so prevalent. And this may be inclusive of embedding behavioral clinicians within the medical home team, as an example, explaining the cost of treatment options to families and providing the connections to resources, whether they be charity care or the different insurance plans that are available through the exchange or through the local state. Additionally, following up after patients give birth, this is in particular to the many maternal and child health disparities that exist. So for this particular population, ensuring that there are mechanisms in place where after patients deliver their baby, their transition to the pediatric medical home and to maternal health continues. And then finally, as mentioned earlier, tracking unplanned hospital and ED visits and promoting outreach to those populations. And then the final category is team-based care. We'll go to the next slide. Next slide, please. So in turning to team-based care, the PCMH practices really must operate as a team, as was mentioned earlier by Peggy. This approach enables the practice to more effectively address its high-risk populations and narrow their disparities without just being provider dependent. In the core standards, the clear definitions for key team members is critical. This allows accountability, organization, a standardization across the practice, and having key team members really function at the top of their licensure, all with the narrowing of disparities in mind and in providing the highest level of care for the practice patients. Additionally, in team-based care, another core standard is to have regular interdisciplinary team meetings to discuss patients that may be having some of these disparities, these social determinants of health affecting their care, and promoting targeted outreach for those with a cohesive care plan addressing the multiple needs both within the medical home and in the community setting. On the elective standards, it will be important to include patients, families, and caregivers and stakeholder committees, and this is really to include all members of the medical home in order to promote a reduction in any biases of inclusion of all groups. This will drive change and it will bring input across the practice. And then finally, having care managers to coordinate behavioral needs, I'd mentioned this earlier, is an example of really providing outreach and resources for families with behavioral needs where many disparities continue to exist. And I'll turn it over to Raina.
Thank you, Dr. Matisse. So all the work that practices are putting into transforming into patient-centered medical homes is working. A growing number of studies document that PCMHs are reducing disparities. In the white paper NCQA published, we cited a number of these studies and their chief findings. Among them are the report from Bob Berenson at the Commonwealth Fund that found that low-income adults with insurance and a medical home are less likely to report cost-related access problems, more likely to be up to date with preventive screenings, and have significantly lower gaps in care when compared to higher income populations. Likewise, a study in the Journal of General Internal Medicine in 2016 showed that NCQA PCMHs cut hospital inpatient use and psychiatric outpatient use for high-risk Medicaid patients living with both medical and psychiatric conditions. And not in the white paper, the recent study by the Patient-Centered Primary Care Collaborative that examined the role of advanced primary care models, such as the Patient-Centered Medical Home, in the success or failure of ACOs. It found that ACOs with a greater penetration of PCMHs demonstrated higher quality, specifically in the areas of preventive services and chronic disease management. And likewise, ACOs that had higher rates of PCMH primary care practices were more likely to generate savings. Overall, it's really exciting to see evidence that this model can work to help people get better care and to help health systems perform better and reduce unnecessary costs. And with that, I'd like to turn it over to Patrick McGuire from the Medical Home Network in Chicago, who will be talking about the fantastic work they're doing to use the medical home model to transform care for their vulnerable populations.
Thanks, Raina, and we can proceed to the next slide. So by way of introduction, my name is Patrick McGuire. I'm the Manager of Delivery, Transformation, and Value-Based Initiatives at Medical Home Network. Medical Home Network, or MHN as we like to call it, is a non-for-profit healthcare innovations organization located in Chicago. We also operate the MHN ACO, which is an accountable care organization that's wholly owned by 9 FQHCs and 3 health systems. MHN ACO is currently in a value-based contract and at risk for 120,000 Medicaid lives. As the operator of the MHN ACO, Medical Home Network is really tasked with the administration of the value-based contract, but beyond that, we're also tasked with implementing the innovative model of care, which is really rooted in PCMH. And the essential premise of the model is really driving care management down to the practice level. So what you're seeing on the left there is a diagram that really depicts that flow of delegated care management from the Medicaid payer down to MHN ACO, and then that federated model where that care management is really happening at the medical home level. And through participation in the ACO, each of the medical homes have the resources and the infrastructure to hire, employ, and embed staff in the medical home at the practice level. And what that really means plainly is that you have care coordinators and care managers, a mix of licensed and unlicensed individuals who really understand patients in the context of their environment because they work in and are from the communities, the same communities as the patients. And so they're really able to understand the confluence of factors that impact patient health, and they're able to develop holistic plans with patients and with a multidisciplinary care team to address those disparities in health that the patients are facing. Basically, it's integrated care teams at the practice level that are working on physical, behavioral, social impact factors impacting health and able to meet patients where they're at, both in terms of physical and behavioral health, but also just physically meet them where they're at across the community. Next slide. And so what you're seeing here is the MHN Connect system. This is kind of the anchor technology that allows this practice level care management model to be standardized across the entire ACO. Up at the top, you see the breadth of this MHN Connect system. We think of it as a care coordination exchange, and it's really connected to 28 hospitals in the Chicagoland area, delivering real-time alerts to more than 200 primary care medical home sites. And it's also linked to the community, bringing in behavioral health and community-based social service organization information. And the result is more than 1 million real-time alerts flowing to those care coordinators and care managers at the practice level. Beyond that, though, on the left-hand side, you see all of the disparate data that's flowing into the system. And the system is organizing that in a way that care coordinators and care managers can understand it and truly act on it. And so the result is really actionable, standardized workflows within this digital environment that allows care coordinators and care managers to understand patient movement across the continuum, but to really develop personalized care plans for that patient based on what we call a 360-degree view of that patient and their utilization, including all of that data flowing through the system. A really simple example of that is one of the medical homes that we work with is across a park from a local community hospital. They're otherwise unaffiliated with that hospital, but because of the real-time alerts in the system, they understand when their patients are there. In multiple cases, they've had patients who are really hard to get a hold of or who they otherwise can't reach, but they see that they're at this hospital across the park. And when we talk about meeting patients where they're at, Our care coordinators will literally go over there, introduce themselves to their patients, begin to form those relationships, say, you'll get taken care of at the hospital today, but I wanted to introduce myself. We're here to help you. Let's set a follow-up appointment right now to get you back to the medical home within 7 days. And based off of those types of interactions, they're really understanding the driving factors resulting in chronic ED utilization, emergency department utilization, and inpatient hospital utilization, and they're able to address those. In one instance, one of our medical homes redefined the way they looked at frequent emergency department utilizers from saying, this patient's really hard to get a hold of, don't bother reaching out, and reflagging them and saying, this patient is hard to get a hold of and they use the ER a lot. Let's figure out what they need and let's figure out a way to accommodate them. And so really pushing that idea of fully understanding patients and then accommodating, working with them to build care plans that truly address their needs. The other piece of information that's flowing into that system called out there on the bottom is the health risk assessment and social determinants. For Medical Home Network, the health risk assessment is really the cornerstone of our care management program. It's the mechanism by which we risk stratify our patient population. It is actually a patient-reported measure. So we're reaching out to members to understand both their health and healthcare history, but also addressable social determinants that are impacting that member's health. Next slide, please. And so that information taken over time has really allowed our care coordinators and care managers to have a significant impact on those, what we think of as social determinants that influence patients' overall costs and utilization. We've been using this health risk assessment with the addressable social determinant question since 2014 and have hired a third-party firm to understand the impact of those social determinants and their predictive factor on patients' costs and utilization. And what we found essentially, and perhaps it won't surprise many people on the phone, is in that green box there. The presence of even one social risk factor dramatically increases a patient's overall costs and utilization. And so working with our care coordinators and our care managers across all of our primary care medical homes, MHN built training and care coordination certification to really empower those care managers to find ways as part of a multidisciplinary care team to work with patients to identify and address those disparities where they can be addressed. And you see a couple of them in that chart there on the left. Things like difficulty making appointments, difficulty getting to appointments, so transportation, or filling prescriptions, or even difficulty paying for prescriptions. In a no-cost Medicaid program like the one our patients participate in, difficulty paying for medication shouldn't be an issue, but what we recognized was that was actually a training issue for physicians that the patients interacted with and for care teams to understand and follow up on prescriptions that patients were being prescribed. Were they able to fill them? Were there barriers? And how can we help them? Same thing with transportation, which is a benefit that's part of the Medicaid program, but patients maybe weren't aware of that. Another example of this, just in practice, is we had a medical home who had a patient who was continuously using the emergency department and even had some inpatient admissions. The care manager, after seeing this over and over and over again, finally went and met that patient in the inpatient setting and understood that that patient had been hospitalized due to complications, exacerbations due to asthma. After talking to that patient, understood that there was a variety of factors and reasons that prevented that patient from ever coming in for primary care, but that patient had been relying on the emergency department because it was, for her, the most convenient way to get care, and it was also in her life the only way that she could get the attention and help that she needed, which was really help with breathing. And so that nurse care manager was able to work with that patient immediately, get her a nebulizer, get her involved in an asthma care management program, and then ongoing, work with that patient. Once she felt good, work with that patient on some of the other social factors like unemployment, difficulty securing long-term housing, and access to fresh foods. And so you see how just taking these factors step by step and really integrating them in a model that looks at that patient as a whole person can really have outstanding results. In the aggregate for the MHN program, we've seen more than a 37% reduction in the total social risk factors that our patients are reporting by operating this PCMH model. I also want to call out on that second line, rates overall health is fair or poor. That's really saying that's how patients feel about themselves, how they view their own health. And we've reduced that by more than 20%. And again, it may or may not surprise some folks on the phone, but that is our most predictive factor of overall cost and utilization, is how patients feel about their own health and the empowerment that they feel to do something about it. And so what's so powerful about this PCMH model in practice is that it really gives care managers the ability, as part of an integrated care team, to understand their patients and to address those needs where and when they see them. And so you see that just in practice, there are powerful examples of the change opportunity that this has in patients' lives. I'm happy to answer more questions about that, but of course would point to NCQA as a resource to learn more about implementing PCMH. And I will now turn it back to Raina for Q&A.
Before we get to Q&A, I'd like to let people know where they can find additional information about NCQA's patient medical homes and how they can help you address your disparities. You can visit us at www.ncqa.org to download a copy of the standards along with the evidence report. I wanted to let everybody know that we will be mailing out to all of the participants on the call today a copy of that white paper, so you will have that in your email box soon. With that, now I'd like to open it up for questions.
So, ladies and gentlemen, as a reminder, if you'd like to ask a question, please use the Q&A panel located on the right-hand side of your screen. Enter your question and then hit the send button. We do have a few questions in queue, and the first one is, how must the 25 elective credits spread across the 6 concepts? I have been searching for this and have not been able to locate it.
Hi, this is Trisha Barrett, a voice you haven't heard yet, but I'm the Vice President of Product Design and Support at NCQA. The specifics to that question, we require that you spread your elective credits across the 6 concepts, but only 5 of them. You only need to earn them in 5 of the 6 concepts, and it does not matter, I see a follow-up question, which of the competencies they fall within that concept area. So anywhere in those concepts, at least 5 of the 6, you must earn some elective credits.
Great, thank you. Our next question, maybe this is later in the presentation, but does your team have any data from practices to show the adherence to these standards directly improves clinical outcomes and socioeconomic needs, excuse me?
Go ahead.
Yeah, this is Paul Cotton from NCQA as well. We have our NCQA PCMH evidence report, which is cited in the slides, the resource slide that Raina talked about before. If you go there, you can see a wide range of, on our website, a wide range of studies that demonstrate the improvements and results that we're getting with patient-centered medical homes. I know we're in the process of updating that report now, and it's something to look at very regularly because the evidence coming out is improving as the longer people have been in a patient-centered medical home, the more improvement they see over time. The things that you do to prevent problems now tend to take years to see effects. So as practices have been patient-centered medical homes for a long time, we're really starting to see the benefits accumulate and become more synergistic.
Great, thank you so much. Our next question. Will the panel discuss how the practice tangibly can be implemented the precedented measures? It is great to see them on a slide, but often PCPs and small independent practices are challenged with limited staff, and it's not as easy.
Patrick, do you want to take that one?
Yeah, I'd be happy to address it, in terms of the context of the Medical Home Network ACO. And I hear the question, you know, addressing issues of resources. One of the driving factors of the success of MHN ACO is really the value-based construct that serves as the wraparound for the programming. And a big piece of that, of course, is securing upfront care management funding that funnels down to the practices to hire that staff. And I know that that doesn't comprehensively address issues in cases where those resources might not be available, but it does, you know, I think play into the role that value-based care has in making standards like this really actionable and really effective in broader healthcare environment.
Great, thank you. Our next question, how many care coordinators are used? Also, how many PCMH does each care coordinator work with?
I think that's to you, Patrick, as well.
Sure. That's a great question. So our care coordinators and care managers are employed by, they're embedded in the practices that they work in. The patient panels who are assigned to care coordinators and care managers, you know, it's all a medical home model. So the patients that the care coordinators and care managers work with are patients who are assigned to that medical home that they are an employee of. It varies based on our participating medical home patient populations. We do have some standards that we adhere to in terms of staffing ratios. You know, I can say at the highest level, one of the most important components of those ratios is being sure that as we risk stratify members, we make sure that those members who are high risk are being actively care managed by a licensed individual. And then we also deploy unlicensed care coordinators who work as part of that care team, but who can, you know, more readily address less complex medical issues and work with patients within, you know, the medical home model to address some of the social determinants as well. But in those instances where a patient is stratified as high risk and we understand that they're complex, they need a little bit, you know, higher touch care management, especially medical care management, that's when we bring in licensed individuals. We use registered nurses. We also use LCSWs for socially complex patients.
Great, thank you. Our next question, how does the consent model work for the MHN network? Does patient consent for the entire system to access their health information or each individual provider in the system?
That also is a super good question. I am not our compliance specialist, but what I will say is that the system itself is HIPAA compliant. It's all secure. So from a data integrity and data compliance perspective is all taken care of. For care management and care management data flowing through the system, patients consent to the care management program. So you know, as I kicked off, our cornerstone of our care management model is that health risk assessment. It's a telephonic assessment or in-person assessment done with the patient for patient-reported data. And part of that assessment is understanding patients' willingness and desire to participate in that care management program.
Thank you. Our next question, what has been people's experience in adding on the distinction in BH integration? I am starting to reach out to our health plan provider about adding this upon renewal.
I'll try to field that one. The question, I think, is asking, have people found value in the behavioral health distinction? And the answer is the jury's still out in terms of seeing actual uptake in terms of payers specifically incentivizing or rewarding that performance. However, there's obviously a movement across the country to improve the integration of behavioral health into primary care in order to meet the needs of, you know, of populations. just in general, and the standards that we put together for that behavioral health integration are closely aligned with state priorities and other payer priorities in terms of their objectives for improving the care for those populations. So I think it's good evidence-based set of criteria. The distinction itself, not yet seeing huge uptake, but there is adoption on the part of, in particular, health systems who are trying to engage more of their providers to provide an integrated care experience for the patients of that kind of network of providers.
Thank you. Our next question, is your program just based in Chicago, or is it more widespread?
That's for you, Patrick, about MHN.
I thought as much. Yeah, so Medical Home Network, is located in Chicago. We're the 501c3 non-for-profit organization. We are the service or the operator of the MHN ACO. The MHN ACO is the 9 FQHCs and 3 hospitals who collectively own that organization, and they are all local to Chicago.
Thank you. Our next question, is MHN a health information system in and of itself, or is it an interoperability tool between electronic health record systems?
That's a really great question, and something that, interoperability is something always at the top of all of our minds as healthcare data becomes, increasingly widespread and data sharing becomes more of a priority at a national level. I would invite conversations, if you have follow-up questions about about the MHN Connect system, about our care coordination exchange and health information exchange, I invite those questions via email. I think those conversations are probably best just taken offline.
Great, thank you. Our next question, is there a cost for participating centers participating in the MHN Medicaid Accountable Care Case Management Program specifically for the medical patients?
Hi, this is Patrick again. I think that question was asking about costs to the patient, to the consumer themselves, or cost to the FQHCs.
I think it was to the practice, yeah.
To the practices, okay, thank you for clarifying. So the ACO model is like any typical ACO model. We're strictly in Medicaid at the moment. The ACO is comprised of its owners. So there's no direct cost to them, but they are the owner entities of that ACO. And they are taking risk on the 120,000 lives that are part of this model.
Great, thank you. Our next question, in your experience, would you recommend that physician organizations become PCMHs to enable practice, transformation, optimization, and success?
I think we'd love to hear from Adriana and Patrick about that.
Yeah, so I'll chime in on that one. So I would say as a pediatrician, enrolling in this entire process and just transforming our practices here at Columbia has just been an amazing experience. Yes, there's a lot of work that happens and there's some heavy lifting, but if you ask all of the providers in our sites, they will not go back to pre-PCMH. Refuse to do so. We've embarked on this transformation, and the team-based approach, finally being given the tools to manage your population more effectively, is something that we wholeheartedly recommend.
Thank you. And our last question in queue. In addition to the NCQA health disparity measures, what additional strategies does the plan suggest independent primary care providers utilized to mitigate healthcare disparities resulting from a lack of health equality. Equity, health equity.
Yeah, Patrick or Adriana, suggestions on ways in which the independent primary care providers might be able to do this work to reduce health disparities by addressing social determinants.
I think what I've seen in some of my colleagues sort of nationally, because my system is a large healthcare system, but individual providers, this allows them to have negotiations around the contracting within the insurance environment. So I know that from their experiences that I've heard, it just brings a model to the table that insurers are interested in, and as Patrick alluded to earlier, the shift to value-based payment is something that insurers are obviously involved in. So this gives a framework and tools for that negotiation process with individual practices. At least that's what I've heard, again, from my counterparts.
Great, thank you. And there are no more questions in queue.
Yeah, great. I just want to thank our wonderful presenters, Dr. Matiz and Patrick McGuire and Raina. I think, you know, everybody that went into healthcare because they wanted to help people. And I think one of the frustrations that I've heard doctors over my long career express is when they can't meet their patients' needs and it's interfering with their patients' ability to get healthy. And I think that this disparities work, while it seems to go beyond the boundaries of what was expected, I think when people went to medical school or nursing school or whatever program they went to, I think the wonderful part is when people can see that their patients are doing better, that their sense of well-being is improved, that their depression, I mean, that table that Patrick showed, I think speaks volumes about how having a more, and it's really a person-centered view of what your work is. And, you know, I'm well aware of how hard it is to be a primary care practice, so I'm not trying to preach about this, but I just want to say that for all the people that do this wonderful work, it really is an inspiration to all of us. So thank you very much.
That's the end of our presentation day. Thank you all for attending. We are sending, as Raina mentioned, we're sending the white paper to all the participants. We're also going to post this webinar on our website so other people can watch it when it's convenient for them. Thank you again for your participation and have a great weekend.